Understanding Medicine.
Professor Aziz Rehman from Medurstand-Understanding Medicine. And today we're going to talk about this condition called celiac disease. The celiac is an Italian word and it refers to abdomen. So since main symptoms of this disease are related to abdomen, so this is called celiac disease, and celiac is also spelled slightly differently in some literature. It is also called celiac sprue because sprue actually refers to the malabsorption and it causes this sprue diarrhea, and gluten enteropathy, and since the cause is related to gluten, which is a protein mainly found in wheat, and the main pathology in the intestine, so we call it gluten enteropathy or gluten sensitive enteropathy. So whatever name you may use, it refers to the same condition called celiac disease. So the introduction, it is an autoimmune disorder, but very selective. It doesn't affect the entire body like many other autoimmune diseases do. So autoimmune disorders very selective, triggered by a specific protein, and that affects small intestine. There may be some specific receptors, some specific protein in the small intestine, the jejunum especially, duodenum and jejunum, and also part of ileum, where this autoimmune phenomenon destroys the mucosal lining of the gut. So there is actually some genetic predisposition because it runs in the family sometime, and it is like 10% if you have celiac disease, there are 10% chances that your children would also have, one or two children would also have it. And basically it is caused by a protein called gluten, but actually not only gluten as a whole protein, the gliadin part. Gliadin is alcohol soluble part of gluten. So precisely it is the gliadin part of the gluten which causes this entire disease process. But we call it gluten because that is the protein. And as a result of this autoimmune destruction, there is loss of villi. Villi are small projections on the cells of the intestine, and there are actually two types of villi, macrovilli and microvilli. Macrovilli you can see with the endoscope, and these are small wave-like structure on the intestine, increasing its surface. Just imagine a towel. So those spicules that actually increase the absorptive surface, and then there are microvilli on individual cells. Both are or may be lost in this celiac disease. And as a result of loss of absorptive surface, that there will be malabsorption. That means there will be no absorption of nutrient that would cause local GAT symptom and also cause systemic symptom that I will elaborate shortly in subsequent slides. So this would lead to multiple deficiencies because all nutrients are absorbed from the small gut, so they will be deficient and there will be various manifestations of this disease. The prevalence is on the increase. We do not know exactly why, but especially in the developed part of the world, and because all autoimmune disorders are on the increase, including this gluten enteropathy. The exact prevalence is not known because it's certainly not rare. But why we do not know the exact prevalence? Because there are very mild cases. There are some moderate cases. So all patients with gluten enteropathy or celiac disease, they do not come to the doctors and they are not diagnosed, and many of them, they have very subtle symptoms and they remain undiagnosed throughout their life. But early diagnosis and management is very important, especially if it is in the children. It could affect growth, it could cause many serious systemic problems. So early diagnosis is extremely important. For that, you need to have a high index of suspicion. Anybody who has compatible symptoms, you should suspect this celiac disease and do the appropriate investigation. Symptoms may be subtle or none. There are people, maybe at least at a certain stage of their disease, they may not have any significant symptoms at all. So this slide will give you the pathogenesis, and first of all, as I said, it has got some genetic predisposition. Certain HLA antigens are more commonly seen in people with celiac disease. And then ingestion of gluten is essential. And gluten is almost universally taken because it comes from wheat. All societies in the world, they take wheat. Some take in the form of bread, others take in the form of pasta, others take in the form of chapati. But wheat is widely consumed. So I think it's very hard to imagine a meal without wheat actually. So ingestion of gluten in the form of wheat is required for the causation of this disease in genetically predisposed people. So this leads to autoimmune phenomenon, and this is a unique autoimmune phenomenon, partly mediated by antibodies and partly mediated by lymphocytes. So this causes localized inflammation followed by destruction of villi. So once villi are destroyed, the intestinal mucosa looks like a very bald surface, and absorptive surface is also reduced. Crypts are increased in size. There may be some hyperplasia of the cells inside the crypts, but on the surface villi are reduced. I'll show you a picture also. So this would cause malabsorption. Malabsorption will manifest in localized gastrointestinal symptom. Of course, if the nutrients are not absorbed in the small intestine, like fats are not absorbed, proteins are not absorbed, carbohydrates are not absorbed, they will pass on to colon unabsorbed, and that will cause fermentation, that will lead to bacterial overgrowth, and that will also cause flatulence, gas formation. So all the gastrointestinal symptoms, bloating, diarrhea, abdominal pain will be caused. And because it would lead to deficiency of multiple nutrients like folic acid, vitamin B12, calcium, iron, so it would cause systemic manifestations also gradually. So starting from genetic predisposition, ingestion of gluten, and then malabsorption. I think in this cascade, we can actually control this ingestion of gluten. That is very critical to the management. Role of gluten is a protein found in wheat and also barley and rye. Barley and rye are also consumed fairly commonly, but of course not as commonly as wheat, but these are also consumed. So this is an important point to be remembered, because once you ask somebody to avoid wheat, that person may switch over to barley or rye. So we have to explain that these are also to be avoided. Then once consumed, it triggers the autoimmune response in those with celiac disease, those who are genetically predisposed, and that leads to loss of villi. Gluten sources are not only these. See, we must remember that there may be cross-contamination. All these seeds are processed maybe in the same machine, and there may be cross-contamination, and I think that would also be responsible for some cases. Now, coming to the symptoms, this disease causes quite a few symptoms, mostly gastrointestinal. Let's first go through the gastrointestinal symptom. There would be diarrhea, or there may be steatorrhea. Diarrhea is simple increased frequency of defecation with altered stools. Stools are softish and may contain some mucus, but I think one very characteristic of this disease, including other malabsorption, is steatorrhea. Steatorrhea is the diarrhea but with a lot of fats in it, and this stool can be recognized by the patient. The stool is very fluffy, it has got a lot of fat in it, it is very foul smelling also, and it floats on water and is really difficult to flush, and patient would also feel as if patient passes fat from the stool when he or she cleans herself, the rectal part. Bloating, because of malabsorption, nutrients go to the large gut where there is fermentation. As a result of fermentation, many gases are produced like carbon dioxide, methane, sulfur dioxide, many other gases are produced, and they cause a lot of distension. In fact, this is such an important thing that patient may have protuberant abdomen, and sometimes the main symptom is actually bloating, not diarrhea, but bloating, of course, is very important symptom. It's a feeling of lot of gas in the stomach. It could pass as flatus, or it may also cause a lot of belching. Then abdominal pain, of course, abnormal stool contents in the large gut and lot of gas would lead to abnormal contractions of intestine, and that may cause very loud sounds. They're called brugmai. Patient may actually complain of that he hear loud sounds coming from the stomach. So, and that may also cause abdominal pain, the cramps, colics. So situated diffusely in the abdomen, may be in the middle part or the lower part of the abdomen. Flatulence, a lot of air pass through rectum, and this is very foul smelling. And then belching, foul smelling stool is also characteristic, because once there is fat in the stool, in the colon, that would attract bacterial overgrowth, and these bacteria, they produce many gases, and of course these gases may be foul smelling, so the stool will be foul smelling. So these are the gastrointestinal symptoms. Now let's move on to some systemic symptoms. Non-gastrointestinal symptoms, because nutrients are not absorbed, so there may be anemia. I think anemia is very common because vitamin B12, folic acid and iron, all three very crucial nutrients required for hemopoiesis are deficient. So patient would have anemia, either hypochromic microcytic or macrocytic or mixed variety, variable level of degree of anemia may be present. Osteoporosis, a premature and accelerated osteoporosis is a feature, because osteoporosis may be seen otherwise also, but these patients, they have premature and accelerated osteoporosis. Osteoporosis may be asymptomatic, may be detected only on investigation or only when somebody gets minimal trauma fractures. Skin manifestation, there's a typical lesion called dermatitis herpetiform that may be seen in some patient. Other patient would have pallor because of anemia. Dermatitis herpetiform mentioned. Then vitamin K is required for clotting factors, and severe malabsorption would cause deficiency of fat soluble vitamins more than water soluble vitamins, and vitamin K may be deficient. If severely deficient, then there may be deficiency of clotting factors including prothrombin, and patient may have this bleeding disorder, bleeding from nose, bleeding from mouth, bleeding from other area, menorrhagia, or there may be bleeding from anywhere. And seizures, because vitamin D deficiency, calcium deficiency can cause hypocalcemic seizures. So I think it's a fairly complicated disease. Fortunately, if diagnosed early, if patient is alert, patient reports to the doctor, and doctor is also vigilant, doctor makes a proper diagnosis and treatment is intervened, treatment is offered at well in time, then of course these things would not develop, and many of them would reverse if you have made a diagnosis, and of course you will also replace all those nutrients which are missing, so many of them would reverse when you have treated the patient. Now in some cases there may be no symptoms at all. So if you have a patient with celiac disease and you screen the family, and some of them may have antibodies associated with this disease and they may not have any clinical manifestation, these patients would require some kind of observations, because when they develop symptom, only then we can treat them. So signs, what are the signs? There may be abdominal distension. This is because of lot of air produced by the colon bacteria, the the bacterial overgrowth, and there may be distension of abdomen. And you can tell that this is not obesity because patient may be otherwise wasted, um, but the abdomen is distended, and this is because of the gas. And if you percuss the abdomen, there may be tympanic tone, because tympanic tone is produced by the gas in the intestine. Overall, patient would show signs of poor growth. If it is a child patient, the child may have stunted growth. Even adults would have a lot of malnutrition signs. Their muscle may be lost. They may have wrinkling. They may have pallor, and it would be very, very obvious from just the look that patient has got some nutritional deficiency. Pallor may be present, and pitting edema. One thing which may be deficient is protein. So if the proteins are, this is a sign of overall malnutrition. If the proteins are critically low, there may be anasarca. That means edema present everywhere, but particularly on feet it would be obvious. It may also be obvious on the sacrum, secretory region, and abdomen. So everywhere there may be edema if the case is advanced and has got severe hyperproteinemia. Then ecchymosis. Ecchymosis, these are bruises. If patient has got a clotting abnormality, he or she may also have ecchymosis. Now this of course portrays the extreme picture. Milder cases would not have any of these. They may just have little pallor and maybe little abdominal distension. So these things would be present only in chronic and neglected cases. Those cases who have never reported to the doctor or they have not been treated properly, so I think they would go on to develop this extreme situation. Complications, if not treated, it could lead to severe malnutrition and then additional complication, multi-deficiency anemia, stunted growth in children, osteoporosis in both genders. Occasionally it may be complicated by lymphoma because there are abnormal lymphocytes infiltrating into the gut. They may cause a tumor formation and there may be seizures. So all these are complications of only undiagnosed, untreated cases. Now, coming to the routine, I think there is very good possibility that on the basis of symptoms and signs, you have figured out the diagnosis, or at least you have figured out few possibilities, and one of them being celiac disease. If that is the case, you would like to have the investigation, and this is the list of investigation. I will elaborate on them one by one: routine labs, specific lab, imaging, endoscopy, and endoscopic biopsy. In routine labs, we will look for anemia, HB or hematocrit may be low, and we also see the red blood cell indices. There may be hypochromic microcytic picture, or there may be macrocytic picture, or there may be mixed population picture. And if you do iron studies, iron may be low, ferritin may be low, total iron binding capacity may be low or high. So I think that kind of picture. Serum protein, particularly albumin, may be low, calcium may be low, vitamin D may be low, and PT or INR may be prolonged indicative of vitamin K deficiency. And if you do stool examination, stool fat contents are increased. And at the same time, it would be important to rule out other conditions which may cause similar symptoms. Giardiasis is still common in our country, so giardiasis can also cause similar picture. Giardiasis can actually cause malabsorption, so I think it would be very important to rule out giardiasis on stool examination, because that would require very simple treatment as compared to long-term or lifelong abstinence from gluten. The specific labs, these are the specific labs. We do IgA tissue transglutaminase. This is actually transglutaminase is a protein, is an enzyme which is involved in the digestion of certain proteins. Now, antibodies belonging to any class, but particularly IgA class, are present. This test is extremely useful, and in fact this antibody test has replaced the previous one, anti-gliadin antibodies and anti-endomysial antibodies. These are also available and they are still done in some cases, but IgA tissue transglutaminase, because of its high sensitivity and specificity and easy availability, this is the investigation of choice. So if you have a case where you suspect celiac disease, you should have IgA tissue transglutaminase. Now this would be positive in majority. Those cases who have very mild cases, those cases who are already under treatment, they are avoiding gluten, the test may become negative. Now, since it is this antibody belongs to IgA class, and we have to make sure that this patient is not one of those cases who have absent IgA. There are people who do not have IgA antibodies, and incidentally, the chances of having absent IgA in these patients in celiac disease is 3 times the normal population. So you would also like to do IgA total and IgA tissue transglutaminase. And if IgA total is absent, then this test will become unreliable. Then you will go for IgG-TTG. So I think IgA-TTG in majority and IgG-TTG in some cases. Anti-gliadin antibodies may be done in children under 2 years. Anti-gliadin deamidase antibodies may be done, and anti-endomysial antibodies, I'm not sure what is the exact place, but these are not done these days. So these are specific lab tests for celiac disease. Very important. I think out of many investigation, this stands out as investigation of choice as a first screening test. Absent IgA tissue transglutaminase would warrant further investigation to rule out other condition. In imaging, imaging is not specifically done to diagnose celiac disease, but if you are investigating a person with malabsorption, and then you are likely to see these abnormalities on X-ray abdomen, you will see distended gut loops with a lot of air. And if you do barium meal study, then you will see what we call flocculation of barium. Flocculation, that means that instead of making one whole column of outlining the intestine, it would be like in pieces. So that is called flocculation. That would be present. This is of course not a diagnostic of celiac disease. This only suggests malabsorption. But if you have antibody positive and there's flocculation of barium on barium meal, so that would mean that this is likely to be celiac disease. Investigation, confirmatory investigation. The investigation of choice, I've already mentioned, IgA-TTG, but the confirmatory investigation, which is not necessary in all, but is very strongly desired, because this diagnosis is going to change one's life. So I think endoscopic diagnosis is very important. On endoscopy, you have loss of villi and intestine become more or less very, very bald or flat structure. But even more important is biopsy. Typically, 6 biopsies are taken from the duodenum or the jejunum. Actually, we pass the scope to the maximum distance, which is usually the second, third part of the duodenum, and then we further pass the forceps, which takes biopsy. So this is a kind of blind biopsies from the small intestine. Some would come from the duodenum, other might come from the jejunum. Traditionally, it used to be jejunal biopsy, but I think duodenal or jejunal biopsy both can give us the answer. Now see, these are the villi I was talking about. So these are the villi, and these are the villi, and these are the crypts. So these entire, look at this surface area, a lot of surface area for absorption of nutrients and also secretion of enzymes. And this is the case in celiac disease. All those villi are destroyed and intestinal lumen has become more or less bald. Crypts are still there and they're hyperplastic, but the surface is reduced to great extent. The absorptive surface is reduced, and you see these lymphocytes. See this part, and compared with this one, normally intestine has lymphocytes, but there is a lot of infiltration of lymphocyte, and they are large lymphocyte. So on biopsy, you do 2-3 things. Number one, we look for these signs, so it is for the diagnosis of celiac disease. And number two, we also do staging. There is stage 0 to stage 5. So there are 5 stages, and this to me looks like the very advanced stage. So maybe stage 5. So that can be used for the grading and also to rule out other condition like intestinal lymphoma. Other condition can also be ruled out. So I think endoscopic biopsy is very important and useful and should be done before we start the treatment, before we formally label somebody as a case of celiac disease. Endoscopy is now available. I think this test should be done in all cases. So that was the lab diagnosis, but let me tell you one very simple trick. That is, if you suspect somebody with celiac disease here, and you have ruled out other condition, and the suspicion of gluten enteropathy or celiac disease is very high, you ask a patient to avoid gluten completely, or at least as much as that person can. Almost complete, maybe sometime impossible. So I think patients should avoid gluten, the wheat and the rye and barley and other sources, and then there should be reasonably long observation period, 3 to 6 months, and then you re-evaluate the patient here. If patient has marked improvement in symptoms, then I think that would suggest that this is actually gluten enteropathy. And then you reintroduce the same diet. Either you do it intentionally as to do the experiment, or patient does it. Patient just can't continue with the gluten-free diet, and then he or she restart and the symptoms reappear. So I think compatible symptom, marked relief of symptom, and then symptoms reappearing when the wheat is reintroduced, that is fairly diagnostic. Now this does not require any lab, it does not require any further resources. You just have to explain to the patient that this is how to go about the diagnosis. Of course, if there has to be marked relief of symptom, not just little bit, because if you avoid wheat, there are some other conditions, there may be some improvement, including a condition called celiac type. I think I'm going to talk about later. So if this is combined with biopsy, here loss of villi and villi regrow if you do endoscopy, and then finally if you, after challenging with the food and you do third time endoscopy, then there will be villi loss again. So this will be like an extreme situation, but I think diagnosis will be then beyond any doubt. So on this slide, what I'm trying to explain is, I think concentrate on these two without any lab, just abstinence from gluten for significant period, re-evaluation, clinical re-evaluation. If there is marked improvement, that might suggest that this is gluten enteropathy in resource deprived societies areas, and those areas where the tests are not available, this technique can be used. The differential diagnosis, every disease has a differential diagnosis. I think we need to consider IBS. In fact, many patients with mild to moderate celiac disease, they are usually treated as IBS because, you know, IBS is a very common condition. So many of these patients are also treated as IBS, but then IBD, inflammatory bowel disease, chronic GI infection like GIDS or other unusual infections, they need to be considered. So, and any other type of malabsorption, small gut syndrome, and there are many other actually diverticulosis. So these should be considered. Now, the main principle of the treatment is to avoid gluten diet. Now, I pulled this list from the internet, and I think this can be shared with the patient, and this can be translated into local language, and these are the things which are to be avoided. And I have also given the percentages. That means, of course, any diet which is high in gluten content, that must be avoided, and the one which is low in gluten, that may be, I think, tried sometime. A patient is very keen to. So wheat flour, which is our staple diet, we take roti, we take naan, we take paratha. So all these are, and we take bakery, all are made of wheat flour. So I think that should be avoided. Wheat bread, because that is refined, it's got even higher concentration of gluten. Pasta has gluten, barley has got gluten, rice got gluten, low concentration. Oats, the variable, actually there are different oats, some have low, some have high contents of gluten. Then seitan, white gluten, actually this thing I learned while I was preparing for this lecture. This is a meat like thing which is produced from the gluten part of the wheat as a meat substitute for those who are vegans or strict vegetarians. So this is actually concentrated gluten. Then of course this would cause a lot of symptoms. This I think to my knowledge is not consumed in our society. Bakery and pizza dough and beer. So all these things, they should be avoided as much as possible. Now I've seen people who, after avoiding gluten diet, once they recover, occasional intake of these things may not cause symptomatology, maybe just little bit of bloating, but may not restart the disease. So I think they should be avoided as much as possible, but occasional usage may be permissible. Now, that means if you are avoiding a gluten diet, you have to give gluten-free diet. And this is just a principle. How do we know this diet is gluten-free? Number one, you should check labels. Very detailed labels you should go through if you're buying something uh, from the bakery or from the superstore. Just check the label. If it is completely gluten free, I think that will be safe for patients with celiac disease. And check websites. There are various websites giving the list of gluten free diet, and there are support groups. There are support groups, I think they share the information. And then there is I think there is an institution that certifies that this diet is particularly gluten free. Then of course you can trust more that if it is certified. Then beware of co-contamination. Something you know is not barley, is not gluten, is not the one which has gluten, but during food processing it may be contaminated with something else, and that might cause symptoms, that might trigger symptoms. So you have to be very careful. Now those who have mild form, they may still be able to consume these things, but those who have severe, they must try to avoid gluten almost completely. Now this is the list of gluten-free diet. I think first of all, since grains are our staple diet, so substitute of wheat is grains, is corn, millet, sorghum, and gluten-free oats. These are grains. And then fresh fruits and vegetables. I think I would also include rice here. Rice probably comes under the in this list later. But if somebody cannot consume wheat, rice is a favorite dish in our country, so he can take rice. And rice can be converted to rotis also. Rice, all varieties. There are various types, but all are gluten free. So one can take rice. Uh, Quinoa is gluten free and rich in proteins, but I'm not sure what it is called in our language, and this is supposedly some good grain. Then legumes, beans and lentils and peas are gluten free. All meat and poultry is gluten free. Fish and seafoods are gluten free. Eggs are gluten free. And then dairy products are gluten free. I think this is quite obvious. Main thing is these grains. I think one has to be sure that celiac disease patient should consume these grains: corn, millet, sorghum, and rice. I think this is very important. Other things we know they are gluten free. And this has to be done for life. Nuts and seeds are also gluten free. Now, this would help in majority. Once patient goes on gluten-free diet, there is very good response within days to weeks. Patients is completely free of symptoms. Bloating goes away, abdominal distension goes away, pain goes away, and patient starts putting on weight, anemia become better. So everything starts getting better once patient is off gluten. But there are cases who may be refractory, who may not respond to gluten-free diet. I think if I see such a case, the first thing I would suspect is that patient is not adhering to gluten-free diet. That is the rules. I think non-adherence is the first cause, but there may be actual refractory causes, and we may give a short course of corticosteroids. You know, corticosteroids are very strong immunosuppressant, and this is an autoimmune process. Short course of corticosteroid, 3 months, maybe max 6 months, tapering dose should be given, and then I think patient should recover. But then there are truly refractory cases. Maybe the intestinal mucosa is so much damaged that even after taking gluten away, intestinal mucosa could not regrow. So that would be truly refractory cases. So once you have replaced gluten containing grains with non-gluten grains, patient should start improving, but you should also correct the nutritional deficiencies. Whatever nutrient patient is deficient, they should be replaced. Now, for example, iron, folic acid, and vitamin B12, they come in combo pills also, but they can be separately replaced also. Now, this is very important. This should lead to improvement in HB. Then vitamin D and calcium should be replaced. If patient is still symptomatic, it would make good sense to give vitamin D parenterally, because if patient is not absorbing vitamin D, even replacing may not correct serum vitamin D. So that could be given parenterally. We have parenteral preparation. Then vitamin K. Vitamin K is also to be replaced, and parenteral preparation should be better. But if patient has started absorbing, then I think oral replacement. These patients I think should be on lifelong replacement, because you never know when they have relapse. I think some kind of replacement should continue for life. Proteins, of course, these patients need to be given meat and poultry and eggs because they are hypoproteinemic. And then we have symptomatic treatment. Of course, the main treatment is gluten abstinence, but symptomatic treatment, like somebody having abdominal pain, we may give spasmolytic. Now, if somebody needs spasmolytic on long-term basis, that will surely mean that patient is not adhering to the gluten abstinence, but it can be given as and when needed. Then because these patients have a lot of gas, anti-flatulent may also provide some relief. So this is the treatment. Then I think these patients need to be followed up. In follow-up, what should be the frequency of follow-up? I would certainly like to see my patient after 3 months with at least one CBC. So CBC would very correctly reflect the overall nutritional status. I would go through the symptom and sign and see the CBC. If everything is okay, then the same treatment plan may be continued. So clinical with basic lab data may be, and IgA TTG titer may be done. I don't think this is necessary. This is necessary for the diagnosis. For follow-up, it may not be required, but it has got some correlation with the severity of disease. If the TTG titer remains high, that means disease is still active. And if the TTG titers are going down, that means disease is dying off. Similarly, IgA anti-ghrenin D-amidate titer can also be done. Endoscopy, just for follow-up, I'm not sure if we can make a case for routine endoscopy just to see if the patient is improving. If patient is clinically improving, there should be endoscopic improvement also. But if you really suspect lymphoma, which I mentioned is actually a complication of celiac disease or one of the rare association, then you might do endoscopy again also. Prognosis, early diagnosis and adherence to gluten-free diet makes a very good prognosis, but problem here is non-adherence. many patients are unable to avoid gluten for life, and sometimes they get exposed to gluten accidentally, sometimes they just can't control themselves and do it intentionally. So if they can actually manage to remain adherent to gluten-free diet, the prognosis is reasonable good, and they would have normal growth and normal HB and normal life. And the late diagnosis or failure to adhere will make the prognosis poor. So this is actually, I'm coming to the end of the celiac disease, but there are two conditions which are very similar to celiac disease. I would like to mention them briefly here. So one is called non-celiac gluten sensitivity. Non-celiac gluten sensitivity, abbreviated as NCGS. So it is similar to celiac disease. Symptoms are similar but milder, and it is not immune in nature, so you will not have those antibodies present, and all diagnostic criteria are the same except antibodies. All diagnostic criteria are normal. There would be no antibodies, and there would be no abnormality on endoscopic biopsy, and there would be the treatment is the same because it is caused by gluten. So I think treatment would be avoiding gluten for life, although probably uh, less effectively. I mean, patient can take a small amount, but I think one should avoid gluten as much as possible. Then there's a condition called wheat allergy. Now, sometimes celiac disease is also referred to as wheat allergy, but actually celiac disease is not the usual type of allergy. That is very specific to intestinal lumen, but there is actual wheat allergy also. Now, if somebody, and this is much rarer than celiac disease, if there is patient has actual wheat allergy, patient is likely to develop all those symptoms or signs which we expect in other allergies like anaphylaxis. It's different than celiac disease. Severe systemic allergy manifestation like urticaria, hives, and maybe bronchospasm, maybe hypertension, anaphylactic shock. And in these patients, since this is IgE mediated, so patient would have elevated IgE levels, and now we have allergen specific IgEs, and you will be able to find a specific IgE against wheat proteins. So this is a kind of allergy, like we have allergy to nuts, we can have allergy to wheat, and this is very, very different than celiac disease. The only thing common is that this is also caused by wheat. Living with celiac disease, and this very important, you just I mean, not only prescribe medicine, you have to provide emotional support, social support, and patient needs to cope these facts also. And there are some support groups patient should find one, and I think would be very, very helpful, and the support group provide all the information regarding diet and tests and everything. So I think emotional support is as important as medical treatment. Very briefly, I'll talk about celiac disease in children, and it is very different because it could cause the problem with the growth. Patient may have stunted growth. Children would not grow in the normal height, and particularly in children. Of course, all features will be the same. There will be failure to thrive, all the same, but early diagnosis is extremely crucial, and adherence to a specific diet will be particularly difficult in children. So I think this is going to be another challenge. Some research and future trends, I think there's a lot of research going on, and there are scientists working on vaccines for gluten neuropathy, but to my knowledge, they are not in the horizon anymore. They're going to take time before we get these vaccinations. So, ladies and gentlemen, conclusion, a common but underdiagnosed condition. Celiac disease is a common but underdiagnosed condition. You need to have high index of suspicion to pick up these patients for further investigation. And IgA TTG is the best screening test, very sensitive, very specific, and a negative test would suggest an alternate diagnosis. positive suggest would mean that you need to go to the further level, which is endoscopic biopsy, because that is confirmatory. And gluten abstinence is the main treatment. Some would require corticosteroids, very few cases, but gluten abstinence is the main treatment and lifelong. And then replacement of nutrient deficiency also, then follow-up. I think some kind of 3 monthly, 6 monthly follow-up is needed just to make sure that everything is working according to the plan, and patient actually needs to be reminded again and again to stay away from gluten. I think with that, I'd like to conclude this talk, and thank you very much for your interest in my channel. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine, and I really look forward to see you in my next lecture, which is going to cover another topic from the gastrointestinal condition. Thank you.